Yes. I think we should start right now. Ajit and Dinesh, are you ready to go?
Yes, doctor.
So we welcome everybody who have joined in right now to the monthly Magna case updates, what we're doing. So these case updates, we like to keep it as practical as possible so that, we are able to address the common day-to-day problems that an endocrinologist or gynecologist or a dermatologist has to deal with on a day-to-day basis, or even for that matter, general physicians. So last time we had good talks on mainly diabetes and diabetes-related acute complications. Today, we'll have another 3 very interesting talks. To moderate the session, we have Dr. KVS Harikumar. He has his own center of Magna in Himayat Nagar in Hyderabad, and he has been the honorary secretary of the Endocrine Society of India for the 3rd year running now. So we hand over to Dr. Harikumar to take over the scientific session today.
Thank you, Dr. Santosh, and good evening, everybody. Welcome all for the second episode of the Magna monthly clinical meetings. Without wasting much time, I'll just briefly tell you, we are going to discuss about a newly detected diabetes or a pre-existing type 2 diabetes, and some interspersed by my talk about thyroid, what to do something in a pregnancy. Okay. So for the first talk, I invite Dr. Lakshmi, who is our center in charge at Mysore. Dr. Lakshmi is a senior endocrinologist who works with Magna and as well as the faculty in the JSS Medical College. Dr. Lakshmi, over to you, please.
Thank you, sir. I'm just sharing my screen. Lights are visible?
Yeah, please.
Thank you, sir. So today we'll have a case conversation. I'm sure that this is a case scenario that most of us face very commonly in our clinics. So a 32-year-old primary gravida comes at 6 weeks of gestation and found to have a fasting plasma glucose of 125 milligram per deciliter. So how do we approach this? Is this pre-existing diabetes, or is this first time detected in pregnancy? Is it gestational diabetes? How do we label this and how do we manage? Just a brief practical overview on this. So just to go into the case details a little bit, this is a 32-year-old lady who presented at 6 weeks, as we discussed. Her pre-conception BMI was 27 kg per meter square. Both her parents are diabetic, and elder sister was diagnosed to have gestational diabetes mellitus at 25 weeks and later developed type 2 diabetes mellitus after 3 years of delivery. So 2 years back, at a routine health checkup, she had features suggestive of pre-diabetes. Fasting blood glucose was 110 and HbA1c was 6%. Her current tests are as follows. When she presented to us, it was 125 milligram per deciliter and HbA1c of 5.9%. So what is the diagnosis in this patient? So before we come to the diagnosis, I will just discuss a few essentials. So the very first question is, why is it necessary to screen for hyperglycemia in early pregnancy? So of course, we do the classical OGTT at 24 to 28 weeks, but why is it really necessary to screen for hyperglycemia in early pregnancy? We have this IAD-PSG study group recommendations in the diagnosis and classification of pregnancy hyperglycememia. So all women, it is recommended that all women are screened for diabetes early in their pregnancy. And when we look at what tests we should be using to screen for hyperglycemia in early pregnancy, so we have various tests like fasting plasma glucose, oral glucose tolerance test, and HbA1c. So there are various cutoffs. So just to tell you a little bit about all of this, the fasting plasma glucose, when we take it, the level drops marginally in the early half of pregnancy. So we take a cutoff of 92 milligram per deciliter. If we say it is more than 92 milligram per deciliter, that is abnormal in early pregnancy. And it has a linear association with risk of conventional gestational diabetes. Now, when we speak of conventional gestational diabetes, it is gestational diabetes which develops at 24 to 28 weeks of pregnancy. And this fasting plasma glucose in the first trimester has a linear association with risk of conventional gestational diabetes and also perinatal outcomes. When we look at the oral glucose tolerance test, the postprandial glucose levels increase around the 16th week of pregnancy and stay elevated till the 36th week. So we have cutoffs for OGTT here. So we have two cutoffs, IAD-PSG criteria and the Carpenter-Couston criteria. So IAD-PSG criteria is most followed world over now. Fasting plasma glucose more than 92 or 1-hour glucose more than 180 and 2-hour glucose more than 153 is suggestive of abnormal glucose metabolism if done. So this also has not an accurate predictor of conventional gestational diabetes. So 50% of values will revert to normoglycemia at 24 to 28 weeks without any treatment. So suppose you have an abnormal OGTT in the first trimester, and then you repeat it at 24 to 28 weeks, up to 50% can have normoglycemia. So that's not very, related to the conventional GDM risk. And fasting plasma glucose component of this correlates with adverse pregnancy outcomes, and the postprandial values not so much. When we look at the HbA1c, from early in the first trimester, HbA1c levels fall. So they reach a nadir in the early pregnancy. And HbA1c values less than 4.8 or more than 5.9% are reasonable cutoffs to rule out or rule in early gestational diabetes. So if you have a HbA1c of more than 5.9%, you can say that this patient probably has early abnormal glucose metabolism. Or if it is less than 4.8, we can rule it out, but between 4.8 to 5.9, we have conflicting data. So going back to our patient who had a fasting plasma glucose as 125, the next question would be, would you label her to be having a gestational diabetes right now, and do we need to monitor her glycemic status? Now, when we look at the ADA 2024 guidelines, it says that early abnormal glucose metabolism. So there is an entity called early abnormal glucose metabolism. This is defined as a fasting glucose threshold of more than 110. So our patient had 125, which is definitely above 110, or an A1C of 5.9%, may identify women who are at higher risk of adverse pregnancy and neonatal outcomes and are more likely to need insulin treatment, or at a high risk of a later gestational diabetes mellitus, gestational diabetes diagnosis. So our patient definitely has an early abnormal glucose metabolism because her fasting plasma glucose was above 110 and her HbA1c was also 5.9%. So definitely there is something wrong here. So when we come to the diagnosis, next is what should we be telling her about her glycemic target? So whether we, ask her to follow a certain diet or exercise, what should her glycemic targets be? So the targets for conventional gestational diabetes from most guidelines are fasting plasma glucose should be less than 95, 1 hour postprandial glucose should be less than 140, and 2 hour postprandial glucose should be less than 120. Now, can we apply these same targets to a GDM which is diagnosed in the first trimester? Now, this was a TogoGM pilot randomized control trial where they looked at women for risk factors for GDM. They were screened at less than 20 weeks in the early part of their pregnancy. And early GDM women were randomized to clinic referral or ongoing treatment or no treatment. Okay, so some patients were referred to treatment very early in their pregnancy, and some patients were not given any treatment. So these were the targets that were followed. That is fasting plasma glucose of less than 95 to our postprandial glucose of less than 122. So early versus no intervention led to a decrease in large for gestational age babies, but there was an increase in NICU admissions largely with the small for gestational age babies. So there was a decreased incidence of LGA with early intervention for gestational diabetes, but SGA increased. So there is a kind of a conflict here that early treatment may result in a playoff, between reducing the macrosonia but increasing fetal undernutrition and small for gestational age. So this is really a gray area, and when we are treating such cases, we should be specifically looking for in USG. In such cases, we should be monitoring fetal growth. We should be doing more frequent ultrasound to detect congenital anomalies, or monitor placental changes, and possibly predict gestational diabetes at very early stages of pregnancy, and also decide on the mode of delivery to avoid potential complications. So whether you decide to treat this patient or not, the role of frequent monitoring should be emphasized to the patient. And if the patient is started early on in the treatment, will the management strategy change after 24 weeks is the question. So as we know, as pregnancy, pregnancy progresses, insulin resistance increases, insulin requirement also increase. So insulin resistance peaks in the later half of pregnancy. So of course, this patient, if she is diagnosed with a conventional gestational diabetes at 24 to 28 weeks, she would require a step up of her treatment. If she's on diet alone, maybe she would require insulin, or if she's on a smaller dose of insulin, her insulin doses may need to be stepped up during the later half of pregnancy because insulin resistance increases. And how would you follow up the mother after delivery in this patient? So postpartum screening is very important. The American Diabetes Association recommends a screening at 4 to 12 weeks. Remember, this is with the 2-hour 75-gram OGTT. Only the NICE recommends FPG, but most of the other guidelines recommend a 2-hour OGTT because it's more sensitive. So at 4 to 12 weeks after pregnancy, you call back the mother and do this 2-hour 75-gram OGTT to diagnose diabetes mellitus, if any, in the mother. And there is a long-term outcome implication for the child in such cases as well: glucose intolerance, type 2 diabetes mellitus, obesity, cardiovascular morbidity, is seen to increase in these patients. Now, when we look at the detail on studies which looked at early GDM, there have been positive and negative studies. For example, these two studies said that the Osmondson study in 2016 said that early treatment in early part of pregnancy did not significantly reduce the risk of GDM except in non-obese women. And the Simmons study, the TurboGM pilot study that I spoke about, said that more NICU admissions are there in the early gestational diabetes group with a tendency for more small for gestational age, but less for large for gestational age. So when we look at screening and treatment, there is conflicting evidence. There are many observational studies with some studies show that early GDM are at high risk for adverse pregnancy outcomes, and some other studies say that they're not really, correlating with the presence of conventional gestational diabetes. So we have conflicting evidence from observational studies now. And RCTs are very few. We know that randomized control trials have more evidence than observational studies. So the TurboGM study is one which I discussed. And there are also ongoing studies like the TESCO studies and PINTO studies, which are looking at this particular aspect, and the results will actually tell us whether it's required to treat patients early in the course of their pregnancy. So just to summarize, TurboGM we have spoken about. So just to summarize, what we all know is where there is no conflict at all, is screening for over diabetes in early pregnancy is very necessary. At the moment, the threshold for diagnosing over diabetes in an HbA1c is 6.5%. And we also know that there is robust data for screening and treatment of gestational diabetes between 24 to 28 weeks of pregnancy. And this is widely accepted, and this is beneficial to reduce adverse pregnancy outcome. But what we need clarity on is, should the threshold for diagnosing overt diabetes be decreased to HbA1c, because we saw a lot of studies which said that 5.9% is the cutoff for abnormal glucose metabolism. Considerable number of women are diagnosed as having intermediate levels of hyperglycemia, like the patient example that I just showed in early pregnancy, and they're labeled as early gestational diabetes. And what is the optimal diagnostic and therapeutic approach for this large group having early gestational? And fasting plasma glucose, OGTT, and HbA1c have been explored as diagnostic strategies. And what is the best? So far, we know that OGTT has a higher evidence compared OGTT, and of course, the fasting plasma glucose component of OGTT has higher evidence compared to other tests. And what is the target glycemic level also remains to be explored. When I showed you the glycemic targets of 95, 140, and 120, it is for the conventional gestational diabetes at 24 to 28 weeks, but we don't really know what is the thresholds in early pregnancy. So what I will do is, when a patient like this presents to me with a fasting plasma glucose, which is more than 110, or a HbA1c which is more than 5.9% in the first half of pregnancy, in the early pregnancy, for example, at 6 weeks when we are screening, I tell the patient that there is definitely an early abnormal glucose metabolism. So these are not thresholds reaching over diabetes. There is definitely an early abnormal glucose metabolism, and I put the patient on diet therapy, and then I monitor the blood glucose with close monitoring of fetal parameters as well. So whether the patient needs insulin or not needs to be decided on a case-to-case basis, but definitely lifestyle modifications will help these patients, and some of them even revert back to normal glucose metabolism and don't go on to develop conventional gestational diabetes. So we need data from well-designed RCTs to throw more clarity on this question, and what are the treatment thresholds for these patients, what is the optimal diagnostic cutoff if we are using HbA1c, and data is still accumulating in this area. So we published this paper recently, the early gestational diabetes mellitus diagnostic strategies and clinical implications on this topic. And we said the same thing. There are limitations in the currently available literature. So, and from the body of evidence that we have now, the fasting plasma glucose of more than 92 can be considered as a plausible threshold for the diagnosis of early GDM. So if somebody comes with a fasting plasma glucose of more than 92 or 110, definitely as suggested by ADA, I would diagnose this patient with early gestational diabetes mellitus and keep the patient under close follow-up. So again, the ADA position statement 2024 said the same thing: screen for early abnormal glucose metabolism using a fasting plasma glucose of 110 to 125 or an A1C of 5.9 to 6.4. And if the values are above this threshold, then you will be diagnosing over diabetes in your patient. Thank you for your patience.
Thank you, Dr. Lakshmi, for that excellent overview. Before others ask question, I'll ask one simple question. Most of the times, patient comes with this report, and the moment you will explain lifestyle or monitoring, they'll say, is it going to go away after I deliver? Is it related to my pregnancy? How would you handle that?
So I tell them that, it is dependent on them. So we've seen data that more than 50 to even 70% in some countries go on to develop diabetes mellitus. So there is a lot of genetic factors also involved, like a positive family history and all that. There are predictors for patients who go on to develop diabetes mellitus, but I tell them that definitely you should be screening at 4 to 12 weeks. So only then we can tell whether you have developed diabetes or not, whether your treatment needs to be continued. Otherwise, we see so many patients who have come in their second pregnancy who have over diabetes already. And they have been diagnosed in their first trimester. And we know that, the congenital anomalies are most prone to happen in the first trimester. And they've already presented at, 10 weeks or 12 weeks. So we tell them that, it's not important whether you medication or not. It's important that your glucose levels are normal for you and for for your future pregnancies as well. That is one thing that I tell, that you have to come back at 12 weeks, and some of us even note down their numbers and call them back so that we don't miss and they don't go off treatment.
And your comment about DIPSI criteria and HbA1c.
So this is a raging war, sir. So I think you will agree with me that if we have the resources to do IAD-PSG, like a fasting and then 1 hour and 2 hour, I would do that, because that is simply more sensitive and specific than the DIPSI. But if there is a woman who has come from far off and is not likely to come again and is not likely to undergo this test, then I would simply do a DIPSI and follow those cutoffs. So in my practice, I follow these two rules. Any test is better than no test, and IAD-PSG criteria are more sensitive and specific than DIPSI. So it depends on the situation, like, based on the resources and how the patient is.
Yeah, Dr. Santosh asked about complication screening in early pregnancy. Now that you have diagnosed some dysglycemia, maybe pregnancy related or not, how about screening for others, looking at micro or macrovasculars?
I've not really thought about this actually. So I don't think an early abnormal glucose metabolism in pregnancy would warrant complication screening initially, especially because 50% of them revert back to normal glucose metabolism at 24 to 28 weeks. Maybe once after they deliver, maybe, when we do the 4 to 12 weeks, and if they are diagnosed with diabetes, maybe that would warrant a complication screening. I'm not really sure about this, and we'll have to look up.
If you have, say, maybe a microaneurysm or something, that would give you a more actually weightage towards that it is likely to progress further, even though your fastings may be.
Yeah, definitely. Yeah.
So some of those will actually give you a clue that because we are not sure, there is so much of confusion about what to label them. So that confusion may get at least minimized if you have a target organ damage at some place. make sense in some patients. Definitely, depending on other risk factors, maybe family risk, obesity, all those things will determine about how to do it. Perfect.
Definitely.
Anybody wants to ask anything directly, please unmute yourself and then just ask. Okay. I think there are no more questions. Most of the things are being addressed quite nicely. Thank you, Dr. Lakshmi. We will move to the second talk, which is more commonly faced and possibly, I would say, more controversial again than the first one. TSH of 3.8 detected for the first time in pregnancy. So this is what I'll be spending about 15 minutes in the next on this topic. I'll mention about 3 relevant facts, 3 practice points, 3 studies by our group, and 3 uncommon disorders, and maybe 3 controversies, which most of the times, as far as hypothyroid is concerned, and I'll conclude. Definitely, hypothyroidism, be it overt or subclinical, is the most common endocrine disorder seen during pregnancy. Fortunately, overt is less, whereas subclinical is more common. The autoimmune thyroid disease, that is just presence of a TPO antibody positive, is seen in about 10 to 12%, but definitely that is also more common. And there is enough ample data to suggest that overt and subclinical both are associated with adverse pregnancy outcomes. So there is no doubt in anybody's mind that we should treat them to the optimum thyroid level. There is no doubt about it. But that optimum is different between different races, individuals, countries, and even guidelines. And fortunately, the therapy is very easy and the simple, most easily available, I would say, ubiquitous tablet of levothyroxine will do the job, provided we should know in what dose and how long and how to monitor all those issues. Some of the key physiological facts which are important in this setting. First and foremost is there is definitely an increased requirement of levothyroxine or a thyroid hormone in anybody who is becoming pregnant because of multiple reasons. Your iodine metabolism changes, TPG levels rise, availability of free hormones reduce, all those things. So you have increase in the levothyroxine requirement. Parallelly, there is increased requirement of iron and iodine. So that is why you require to have a fortification at that time or possibly an increase in the dose of levothyroxine at that time. And the most important thing to know is the thyroid gland in the fetus is the first endocrine gland to be formed and be functional by about 20 weeks. So by and large, after 20 weeks, whatever replacement you are doing is actually to the mother, and it is not, the T4 is not going across to help anything in the baby. So that is important fact to understand that after 20 weeks, by and large, the fetus is independent of the mother. How to diagnose the subclinical hypothyroid? The latest or the last published guidelines are the 2017 guidelines by ATA, which are widely recommended, widely quoted. The only thing, if you look at it, the maternal hypothyroidism is defined as TSH elevated beyond the upper limit of pregnancy-specific reference range. Now, to identify a pregnancy-specific reference range, you have to have a normative data with no goiter, no antibody, normal iodine intake. All those factors have to be taken before you generate the normative data. So that is why if there is no availability of it, you should look at whoever has the closest mimicking population. If nothing is available, they said you can use 4 as the upper limit of the cutoff, depending on the assay also. So this is what is the recommendation from the AT. If you look at how to treat, there are again difference in the guidelines. That is recommended is like where the definitely a levothyroxine is recommended. If you have TPO antibody positive and TSH is more than the reference range. As I said, reference range, you need a standardization to establish it. But nevertheless, if you have antibody positive and TSH more than the reference range, it is recommended. If TPO antibody is negative, any TSH above 10, you will treat. It is not overt hypothyroidism. Some of you will consider it as overt. It is not overt. Overt has got nothing to do Overt is only a TSH more than any value with a suppressed or a low T3, T4. So TSH more than 10 alone do not make them overt. It may still be a subclinical hypo. The levothyroxine may be considered in TPO positive and TSH more than 2.5. Here it is the quality of evidence is about low quality. In TPO negative and TSH more than the reference upper limit and but less than 10. So this is the spectrum of what we call the given patient who falls into this spectrum may be used if it is TPO positive and TSH more than 2.5 or TPO negative if it is more than the reference range but less than 10. Levothyroxine is definitely not recommended in somebody who is got normal TSH and antibody negative. So this is one thing, like don't give any low dose levothyroxines just to prevent some unknown pregnancy complications. It is just not indicated. After all, it's a drug. You need to be careful, judicious whenever you are prescribing this. Starting dose, depending on the TSH value, depending on body weight, there are multiple guidelines which suggest so. In somebody who is already taking, the guidelines do recommend that you just give 2 additional doses whenever their pregnancy test comes positive, just to cover up for that early increase in the requirement in the initial trimester. And you need to monitor every 4 to 6 weeks and adjust to keep the TSH in the gestation specific, trimester specific level. So the TSH in the specific ranges less than 2.5 in the first trimester, and depending on the POP normative data, maybe less than 4 or 3.5 or 3 as per the old guidelines. And monitoring irrespective of treatment, whether you are on treatment or not on treatment, should be done every month thyroid profile till 20 weeks of gestation. This is why, because even you may be normal in the first screening, maybe at 6 weeks or 8 weeks. Because of the increased requirement, your TSH may start rising at 12th week or 13th week. So it is important to monitor the patients, whether they are on treatment or not on treatment, till 20 weeks every month. And the monitoring in subsequent after 20 weeks in patients who have got therapy or who have got antibody positivity or other situations. Question comes about, most of the conflict or debates comes about this spectrum, which is euthyroid TPO positive women. The guidelines say very clear, there is insufficient evidence to determine whether it decreases the pregnancy risk. However, administration to TPO antibody positive euthyroid pregnant women with a prior history of loss may be considered, given its potential benefits in comparison to minimal risk. So it's a weak recommendation, low quality evidence. In practical terms, what we do is, if it's a primary gravida doing well, otherwise you need not treat. But bad obstetric history or something, you should definitely consider giving them levothyroxine. One of our first studies which looked at whether antibody negativity or positivity plays any role as far as the pregnancy outcomes. This was, we divided them into 3 groups where antibody status was known, unknown, or positive. Only the TSH was the one which looked at, which determined the outcome. So we say adverse pregnancy outcomes were not different in 3 groups with adequate thyroxine replacement, irrespective of thyroid autoimmunity status. So it is like, basically it is irrespective of TPO. If you, as long as you keep your TSH in the normal range, you will have a good outcomes. Some of the studies or some of the, I would say, websites or maybe others which advocate these complementary and alternate therapies, please don't use any of them. They are not supposed to be used. And IV immunoglobulin, selenium replacements, all those things are not there. T3 to some extent is coming into play in some adult hypothyroid, but T3 is the one which is not recommended for pregnancy or in even ladies who are planning for pregnancy. So it is not indicated in this setting. Once you started the management, how to go about after delivery, if somebody is a known overt hypothyroid, you reduce the levothyroxine to their preconception dosages. In somebody who has started during pregnancy, and if the dose is requirement at the time of delivery is less than 50 microgram per day, you can safely stop and rescreen them after about 6 weeks of stopping, and then reassess them depending on what is the value at that point of time. These are a couple of studies which we looked at levothyroxine dosing after delivery in women diagnosed during pregnancy. People who have got goiter and autoimmunity were the only ones who required a higher dose even subsequently after delivery. And another study which looked at again the follow-up, how did the majority of patients fade after stopping the therapy, increasing in the age, presence of goiter, positive family history, and thyroid autoimmunity. They were the ones who predicted that these ladies are likely to have a hypothyroid later on in the follow-up duration. Few uncommon issues which generally patients ask or worried about or maybe perturb more is about the low IQ in baby. The most of the times, the first question the mother will ask is, will my child be a normal child? Please understand, 99.9999% the child is going to be normal. I won't say 100 for the sake of the data and clarity, but it is as good as a normal child. There is enough data to suggest this was a recent meta-analysis which published 2 years back. Previously, the data was mostly, I would say, derived from the Hados group, which looked at 4 to 7 point IQ loss in the offspring at about children of 5 years follow-up. But subsequent long-term studies, even 9 years assessment, all those things have looked at and more robust assessment or maybe started at an early age. They said that it is not much of an issue as far as the mental function in the child is concerned. So not much to bother. But at the same time, you need to reassure the mother that it is not going to be a problem as long as she's taking the prescribed dosages. Second commonest worry is whenever you check for a TPO antibody, it comes as more than 1500 and then the mother starts jumping around that how to get this down. There is nothing required to get this down. Whatever the TSH value is the most important one. The presence or the value, even the quantitative value of antibody has got no meaning as far as the treatment issues are concerned. Please, for heaven's sake, don't give any steroids or anything to bring the titer down. It is of no use and it is going to cause more harm to the mother rather than any gain. Irrespective of TSH, I said irrespective of TSH, never ever advise a MTP for this. Even if the mother is first time detected TSH more than 500 or more than 150, nothing to worry. You start treatment, that will do the job and you don't have to worry about the, as I said, the low IQ in the future baby. Few controversies. As I said, the first controversy itself is based on the diagnosis. If you look at, this was the original US population from where most of the ATA guidelines prior to 17 were derived, which looked at 0.1 to 2.5 in first trimester, 0.2 to 3 in second trimester. Couple of Indian studies also did have, and which they kept the upper limit up to 5.78. But as I said, you have not assessed in some of these studies for lacking for their thyroid antibody status and adequacy of the iodine intake. They presume that since it's a iodinization, universal iodinization, but you need to assess the iodine intake and urinary iodine excretion to say that they were iodine sufficient. So that is where the, because of this controversy only, the diagnosis also is changing. And you see the number of associations, number of different guidelines, depending on the country of population. You have plenty of different guidelines exist. A very good summary, I would say the conclusion is, additionally, these guidelines need significant improvement. I mean, you may have guidelines, but which also require some improvement as far as how to give the information. ATA says something and ACOG says something as far as in the same given clinical setting. If you have ACOG gives more of a, I would say, traditional or I would say more conservative approach, whereas the ATA is more aggressive approach as far as the management is concerned. That is a basic difference. ACOG more or less asks you to confirm everybody with a free T4 to diagnose. But this generally we don't do in the clinical practice because of the issues concerning the free thyroid hormone estimation. The need for dynamic clinical guidelines. Most of the times, if you have a presence of subclinical hypo in the second trimester, we're not sure whether it will change the pregnancy outcomes or not. So some of the guidelines were not clearly identified in this. And in patients, more or less now evidence is emerging that even if the antibody is negative, if you have mild elevation in the first trimester, you should be aggressive in treating. And in patients who are going for assisted reproductive therapies, maybe not much of benefit is seen in that spectrum. So for the given case with a TSH of 3.8, first time detected, first trimester, there is no doubt you should treat. Second and trimesters, plus or minus. But this the approach is, if you are here, if your antibody is positive, definitely you should consider treatment. If the pregnancy is as a result of assisted reproductive technique, possibly you should treat. Past history of recurrent pregnancy loss, again you should consider treatment. If nothing else is there, maybe the enough iodine and monitor regularly and see how the TSH fares and then take a call about treatment. So to conclude, hypothyroidism is common during pregnancy, in fact the commonest one. Optimum function improves pregnancy outcomes. Beware of the trimester specific ranges. You should be dynamic every month to change the levothyroxine dose as recommended. Avoid the pitfalls in diagnosis and management. Thankfully, as I said, it is a minimum risk with the tablet and maximum benefit will be the guiding in this management issues. Thank you. I shall be happy to take any questions or comments.
So I will ask the questions now. So Dr. Neelam Jain is asking, what is the protocol for discontinuation of thyroxine postpartum?
Okay. Discontinuation basically depends on, I presume that the onset was during pregnancy, as I've shown in one of the studies. If onset is during pregnancy, what is the initial TSH value? What is the levothyroxine dose at the time of delivery? And what is the body weight? All these factors will determine how you discontinue. So if you're requiring maybe a 12.5 or 25 and your initial TSH to diagnose was say maybe 4.5, you can consider stopping. But if there was an antibody positive at that point of time, maybe you continue thereafter, looking at family history and other things. So all these factors will determine. By and large, keep all these things, and then you need not be more aggressive in treating after delivery. If the requirement is 25 to 50, you can consider stopping thereafter.
Dr. Ananta Padmanabhakshmi is asking, how do you counsel a mother who has TSH greater than 10 in the first trimester? What all do you need to tell her?
Most of the, as I said, first thing is you reassure about the child's IQ. So there is nothing which you are going to lose by not taking. Second thing, you should educate her to take tablet regularly in the prescribed dosages, what you have prescribed depending on body weight and other things. Third thing, in case if you have missed the dose, you should remember whenever you take it, because sometimes first time is a lot of vomitings, all those issues. We do in some cases give it in the evening times or afternoon times, give a 3-hour window from the last meal. So that can be done. Fourth thing is to monitor more frequently, because somebody who has been a hypothyroid, generally in non-pregnant states, we do once in 6 months or once in 3 months. So they say, why are you asking a repeated check? So you need to educate them that it depends about more fluctuation, more changing requirements. So that is what you need to educate the patient. Salt intake is one thing which you need to tell the patient about. Don't use these pink salts or rock salts. Hypothyroids 100% require a iodine salt.
And what about iron and calcium supplements? Would you like to throw some light on that?
Iron calcium supplements as a routine, generally not given even in the first trimester. Iron is only given if somebody is anemic, but calcium and vitamin D, definitely most of the Indian diet, and even then it is not adequately supplemented. But after first trimester, we do give them depending on their baseline status. But not recommended as a routine for all hypothyroid patients.
Yeah, just one thing I'd like to point out here is that if anybody who's on iron and calcium supplements, you have to ensure that they are taken 3 hours after the thyroid tablet, because calcium and iron in pharmacological doses, they will interfere with the absorption of thyroid. So at least keep a gap of 3 hours. Don't give iron during breakfast time and lunchtime, because that might cause variation in the TSH as we are going ahead. I think those are the questions that are there. So we'll hand it over back to you, Dr. Harikumar.
Thank you, Dr. Santosh. Now we move to the last talk of the day. Dr. Varun will speak about how to handle somebody who is already a known diabetic and in pregnancy. Dr. Varun, please.
I hope my screen is visible.
Yeah, perfect.
Yeah. So, good evening, all. So, the third case scenario is a 30-year-old lady with pre-existing diabetes. So, regarding the medications, like had not been provided information, but the HbA1c was 8.5. So, not very nicely controlled diabetes, and she has just come with urine pregnancy test positive. So over the next 15 minutes, we will, in addition to the gestational diabetes related risk, the risks. So what are the additional risks of over diabetes? Somebody is having pre-existing diabetes. And so one thing that was missed in this patient was preconception counseling. So regarding preconception counseling, and then we will go to how to manage this patient. So in addition to the preeclampsia or other maternal and fetal complications, so if a lady is having pre-existing diabetes, the risk of congenital malformations also increase, especially the glycemic control during 6 to 8 months, wherein early organogenesis happens. If the glycemic control is not good, with each increase in HbA1c of around 1%, the relative risk of various congenital malformation increased by around 1.5 to 2 times. So it is very pertinent to counsel all the uh, reproductive age females regarding the risk of these congenital malformations, and accordingly to use contraception, especially when the blood glucose levels are not under control, and always plan to bring the HbA1c down to around 6 or 6.5 before planning for pregnancy. So important components are education regarding complications and importance of glycemic control, and use of contraception till ideal glycemic control is achieved. And in addition to the education part, it's also important to assess the diabetes complications, because if if a lady like planning for pregnancy is having a retinopathy or nephropathy, so these can get worsened during pregnancy. Although the long-term outcome of retinopathy or nephropathy may not change, still, if any interventions are necessary for retinopathy, better to plan before pregnancy. And also, if somebody is having just pre-existing hypertension, so important consideration is that ACE inhibitor and ARBs have some teratogenic potential. So these has to be modified to drugs which are safer during pregnancy, like labetalol, hydralazine, etc. And for all pregnant reproductive age females planning pregnancy with diabetes, better to start on folic acid to prevent the to decrease the risk of neural tube defects. So coming to this patient, like so there are we will discuss regarding management during pregnancy under these headings. The most important thing is how to achieve the optimal glycemic control, and then how to what are the like comorbids that have to be screened and how to manage them, and then how to screen for diabetic complications, and then the optic surveillance. So of the management of like the diabetes, and in pregnant females with diabetes also, that's very important. So if the patient is on any other oral hypoglycemic agents apart from metformin, these have to be stopped. If metformin is patient is already on metformin, that can be continued. And so across all the different endocrine society or a different gynecological society. So the insulin is first line. Also, according to DCGA, the insulin is the first line choice of medication for a patient with even both over diabetes in pregnancy or gestational diabetes. So for majority of the patients, we will be giving MDI therapy, wherein basal bolus regimen gives us a better control with lesser hypoglycemia than premix insulin. So like this patient, like we will like to start on basal bolus regimen with basal doses of around like 0.1 unit per kg and along with boluses before meal as required. And for those patients who are type 1 diabetes, may continue insulin pump if they're already on insulin pump. For the choice of insulin, and also while choosing these regimens, like suppose if it is a pancreatic diabetes or type 2 diabetes with a very labile glycemic control, then insulin pump can be considered during pregnancy also. And considering the choice of insulin, which one to use, so majority of the guidelines give that detimer or NPH uh, is preferred because of a larger safety data which is available. However, even the newer analogs like IDEG or IGLAR also can be used, and these agents give us better control with significantly lesser chance of hypoglycemia. So depending upon the requirement, we can definitely use analogs. And some of these newer insulin analogs have RCT data also, which have come recently. So coming to the role of metformin. So the metformin usage of metformin during pregnancy has significantly increased over the past 1.5 decade. So one important concern is slightly increased risk of small for gestational age. So the largest randomized control trial for assessing role of metformin in over diabetes in pregnancy was MIGHTY trial, which included patients from Europe and North America, wherein although the extreme LGA patients incidence has decreased, the SGA, like small for gestational age incidence, has significantly increased. So especially when there is a risk of ICA, like in uteroplacental insufficiency, during growth monitoring, if the centels are dropping in those patients, at least we need to discontinue metformin. Coming to the goals of glycemic control, so majority of the guidelines have uniform uniform like cutoffs for the glycemic control, ranging from like 90 to 95, and post meal at 1 hour is preferred compared to the 2 hour, as the HAPO study also like has included this 1 hour less than 140 milligram per deciliter with minimal risk of hypoglycemia. On glucometer, it's defined as less than 70 milligram per deciliter. If the mothers are using CGMS, then 63 is taken as the cutoff of hypoglycemia. So the monitoring of blood glucose overall in diabetic patients has changed significantly with the advent of CGMS, wherein we are using target in range TAR and TBR as additional measures in apart from HbA1c. However, the cutoffs during pregnancy are not very clear. So for type 1 diabetes pregnant patients, of course, we would want uh, targeting range similar to adult patient with adult type 1 diabetes, more than 70%, since the risk of hypoglycemia will be more. But for a patient of gestational or type 2 diabetes with pregnancy, the risk of hypoglycemia will not be that high. So we would want a higher targeting range. The exact targeting range, like as of now, like none of the societies are giving a cutoff, but we can keep it as close to normal as possible. So there have been like a study called as concept study, which is also a multi-center study, which has assessed the how useful the CGMS is in comparison with the self-monitoring of blood glucose. With the continuous usage of CGMS throughout the pregnancy, not just the HbA1c, the targeting range improvement also was there. In addition to this, for the hard outcomes, the neonatal outcomes also, some of the neonatal outcomes, the incidence of neonatal hypoglycemia, were also lesser in the subgroup with who were on CGMS as compared to the mothers who were monitoring on using a glucometer. Coming to the screening for other diabetic complications. So even if somebody does not have any prior retinopathy, definitely at the time of pregnancy and confirmation, and at later in third trimester, it's better to screen. mothers with mild retinopathy may not require any progress to any vision loss causing severity of retinopathy. However, those who are having moderate to severe retinopathy have to be monitored very closely and have to be in follow-up with ophthalmologist during pregnancy also. And in case of any nephropathy with proteinuria, we cannot give ACE inhibitor or any of the disease for that matter, like SGLT2 inhibitors or the ACE inhibitor ARB drugs during the pregnancy. Especially if the proteinuria is high, we have to consider thromboprophylaxis. And one more important consideration that has to be kept is diabetic ketoacidosis. So pregnant patients are at the state of as such pregnancy is a state of ketosis, and they are at risk of euglycemic decay, although not so common in type 2 diabetes mellitus. However, definitely can happen, especially when persistently the blood glucose levels are more than 200 or 250 milligram per deciliter. It makes sense if any additional symptoms are there to check ketones and blood gas analysis also. Coming to the other comorbidities, hypertensive disorders. So we have to, in case we have to screen the blood pressure also at each visit and can consider safe antihypertensives. And in case of placental insufficiency, aspirin at higher doses, more than 100 milligrams or 150 milligrams has to be given to prevent small for gestational age or other worse outcomes. And in type 1 diabetic mothers, it's important to screen for hypothyroidism also if she is not hypothyroid already. In addition to that, obstetric surveillance will be done by our obstetric colleagues according to the guidelines. And peripartum time, it's important the steroids, betamethasone, which is given for fetal maturity, usually causes a significant jump in the sugars, which is around peripartum. So we need to increase the basal insulin around 25 to 40%, and the increased blood glucose levels usually sustain for 3 to 5 days. So insulin has to be titrated, and as the sugar levels drop down, we need to decrease the insulin dose. During the labor, depending upon the requirement, patient can be kept on variable rate insulin infusion and immediate postpartum period. For type 2 diabetic mothers, we can reduce the insulin doses significantly, or it can even, depending upon the doses, stop and monitor the blood glucose levels and decide on further therapy. For mothers with type 1 diabetes, we can bring down the dosage to around 50% of pre-pregnancy insulin dosage and gradually increase the dosage depending upon the glucose monitoring. To summarize, in patients with overt diabetes mellitus, we need, first of all, we need to give preconception counseling to all reproductive age females who are planning pregnancy or otherwise also. And the management of these patients with lifestyle modification insulin plus or minus metformin is similar to gestational diabetes management also. And it's not when we are treating these patients with overt diabetes or gestational diabetes, it's not just about the patient. So increases the risk for the next of diabetes for the next generation also. That has to be kept in mind. Thank you for patient listening. We will go for discussion, I guess.
Thank you, Dr. Varun, for that nice summary and approach and how to handle type 2 DM. One of the common apprehension, or maybe the question which most of the times you will get is my child going to get diabetes, or what is the risk of his or her diabetes? So what would be your advice to the patient?
So I think if only one parent is having over diabetes, I think as far as I remember, it ranges around 2.5. The risk for type 2 diabetes definitely for the next generation is increased. However, if the blood glucose levels during pregnancy are also not controlled, that additionally gives some epigenetic changes, and the risk of type 2 diabetes for next generation is even further increased. So that can be curtailed with optimal glycemic management.
Correct, absolutely correct. And that is one place where we need to emphasize or educate about the lifestyle, even not only during pregnancy, but you should continue these habits for the rest of the time and keep the, child will not contract diabetes from you, but since he'll contract the same genes from you, you have to ensure that you be in a good lifestyle and set an example for your offspring also that they follow a good lifestyle so that the risk is mitigated. Absolutely correct. Any questions or comments from anybody?
Sir, I have a question, sir.
Yeah, please go ahead.
This is for you only, sir.
Yeah, please go ahead.
Your thyroid case, you said that antibodies comparison with TSH levels and antibodies and the outcome in one of your
Correct.
slides. So
Correct, correct.
antibodies was not very much useful or informative.
Correct.
Only TSH is very important. If that
As
is the
far as
case,
the
then why
outcomes are concerned, yes.
then why we have to do antibodies level for all the pregnant ladies?
Yeah,
If it
very
is not
good.
beneficial in the treatment.
Yeah, the issue, a very valid question. Why we have to do is to determine the treatment to prognosticate the fluctuating requirement. If suppose, as I said, if you have a TSH value of say more than 10, there is no problem. Maybe even more than 5, there is no problem. But for somebody who has come as 3 or 4, on what basis you are going to give your levothyroxine? You cannot give levothyroxine unless you have an antibody positivity. What I showed in my slide was, in our study was, the outcomes were determined based on the TSH. As long as you kept your TSH in the normal range, whether they are antibody positive or negative, the outcomes are not going to change. So the idea is antibodies we may determine about your therapy, but as far as your outcomes are concerned, you should keep a good gestational age specific, trimester specific TSH. Just because your antibody is positive, your TSH is in the normal range, will not lead to additional adverse outcomes. I hope I have answered.
Yes, sir. Thank you, sir.
Anybody else? Any other question, comments?
So what is the cutoff for cord blood TSH, sir?
Cord blood, if you the neonatal screening, it is, you can say 20, but now it has come down to 10. By and large, you take it as 10 nowadays. Earlier, it used to be 20, but anything beyond 10, we are looking at now giving some treatment for them. Below 10, definitely don't treat all these neonates and infants. That is either cord blood or you screen it third day. Don't screen on first day and second day.
Thank you, sir.
So I think thanks one and all for the interaction that we have had today. And thanks to the 3 speakers who have done a wonderful job in presenting 3 very typical scenarios, but quite difficult to handle scenarios. And with that, I would just like to have a few words about Magna. So Magna Centers for Obesity, Diabetes and Endocrinology, we started in the year 2013. We started with initially a few centers only, but now we are proud to say that we have 8 endocrinology centers all over India, which include 4 in Hyderabad, 1 in Bangalore, 1 in Mysore, 1 in Chennai, and 1 in Greater Noida. So we take great pride in working together with doctors, especially gynecologists, obstetricians, dermatologists, and general physicians in treating the patients rather than treating it ourselves. So we always take great pride in working as a team with whoever has, is the primary treating physician of that particular case. So with that, I would just like to have a short 1-minute video which has been prepared by our team. After that, we can close for the night and meet again the next month with some 3 different topics. So I thank one and all for participating in this conference, the speakers, the chairpersons, and obviously all the people who have come to hear us and also had a very good interactive discussion with us. So we will catch up once again after 1 month with 3 more interesting topics. With that, thank you, good night, and we'll meet again next month.
Thank you all.